Welcome and thanks for pressing play. This episode of War Docs was made possible by a partnership with the Defense Strategies Institute's OpMed TV and was recorded at the 2024 Operational Medicine Symposium in San Antonio. These interviews focus on optimizing military medicine through the modernization and implementation of policies, education, training, research, and development. We also explore emerging technologies to enhance the health, strength, and survivability of warfighters. Welcome to this special edition of War Docs in collaboration with OpMed TV. I'm your host, Dr. Doug Soderdahl, retired Army urologist, and I'm joined today by my guest, Captain Carlos Williams, and he is currently the director of the National Intrepid Center of Excellence at Walter Reed. So thanks for being here today.
Thanks a lot, Don, for having me.
Hey, so tell me a little bit about the Center of Excellence, this National Intrepid Center. What do you guys do there?
So National Intrepid Center, what we call NICOE, was actually stood up in 2010, and it was stood up as a result of many members coming back from war in Afghanistan and Iraq. They were diagnosed with what we call the invisible wounds of war. So what happened was the Fisher family, through the Intrepid Fallen Heroes Fund, made a commitment to the Department of Defense and to our service members to get after and understand TBI. And so they built NICOE, which again, National Intrepid Center of Excellence at that time at National Naval Medical Center in Bethesda was the first. And so our goal is to focus on treatment of patients with TBI and associated conditions and really get after understanding through research and education for TBI.
So going back into the history of this, who was really the driving factor of setting this program up?
Yeah, so it was actually with the Arnold Fisher family. It's the Arnold Fisher family. Many of us know Arnold Fisher through Fisher House, or the Fisher family through the Fisher houses. They actually built NICOE, then they built Fort Belvoir's ISC, and then the list goes on. Today, the NICOE is headquarters for the Defense Intrepid Network for TBI and brain health. And we have about 13 sites across the military health system. 11 of those sites were built by Fisher family, and then we have 2 extra sites, one in Lunchstow and one in Joint Base Elbendorf-Richardson in Alaska.
So how did they decide that TBI was going to be that focus?
Yeah, great question. You know, one of the reasons that they did that was in 2008, Congress recognized that we had this disease that they just didn't understand. So we would see members come back from combat and they came back fully intact. So there was no physical scars that you would see, but they saw cognitive decline. They saw other behavior associated conditions such as PTSD, and the common factor was concussion. And so because we didn't understand it well, Congress said there would be a mandate for the Department of Defense to understand this, treat this, and get those members back to combat or get them rehabilitated and transitioned. And so that was the main reason why it was done. It was a congressional mandate, and it was a matter of really and truly readiness for our military forces.
Now, who was in charge of funding the research that went into helping diagnostics and treating? How did that all take place?
So it's kind of unique because the buildings are built, and I would tell you, I run NICOE is one of the most technologically advanced treatment centers for TBI in the world, bar none. We have equipment and supplies there that only exist in the department, in one place in the Department of Defense there. Our model of care is unique because it's the interdisciplinary model of care. Now what that means is that you heard of multi-D or multidisciplinary. We take it to the next step. So we do what we call the interdisciplinary model of care. Interdisciplinary model of care is where we have over 18 different specialties under one roof, and they're working towards treating those individual patients. So we have individual treatment plans. We talk and we discuss as we develop those treatment plans. Nothing is done in silo. And we realize that is the most effective way to treat the patients. So research is the other reason that we exist. And so that research was initially set up by DOD. And so what happened was, once the Intrepid Fallen Heroes Fund builds the building, they outfit the building as well. So we have things like our CT scans, our MRIs, our magnetoencephalography, which is cutting edge for brain mapping and other activities, all in that building that was provided by the Intrepid Fallen Heroes Fund. And then what happens is that DOD provided the personnel, and we took off. And so again, the model of care is what makes us all unique, because all of us utilize that unique model of care, that interdisciplinary model of care for TBI and brain health.
Now, in the Center of Excellence, what percentage of the staff are active duty, or is it mostly contractors or GS?
It's unique because the majority of NICOE and frankly all of the ISCs, what we call Intrepid Spirit Centers, and the TBI clinics under the Defense Intrepid Network are largely civilian, so GS employees and contract. We have a small smidging of active duty. I mean, at my organization, it's about 2 or 3 of us, officers, and then we have several enlisted. But when you go to each one of the sites, you see that mirrored. We have a huge partnership with Public Health Service Corps, so many of them serve as directors of some of the sites that we have. But it is largely a civilian-based organization in terms of staff and personnel at the sites.
So I know that a lot of progress has been made since that 2008 timeframe of being able to diagnose what we see now as TBI.
That's right.
Can you kind of explain where we've gone over that period of time from seeing just a set of weird symptoms and kind of putting it together and going, that seems associated with a concussion,
Right.
to what diagnostics do we have today and technology that we can use to maybe have a point of care ability to have a risk factor assessment for someone who has a concussion or has, some kind of concussive event?
I'll give you a couple of examples of how we've actually made significant progress. So in terms of diagnostics has come a long way, but it is not ready for prime time yet in a lot of areas. But what we've learned is what works for rehabilitative purposes for our members. The interdisciplinary model brings on board the non-traditional treatment pathways: art, music, dance, therapy. We have a huge partnership with the National Endowment for the Arts, where we utilize those therapies for treatment. We have canine programs, we have gardening programs. So what I'm getting at is that we've realized that it can't be just straight medicine. It really has to be a holistic approach. A lot of the patients who have TBI, we also understand that they have psychological conditions associated with it as well. PTSD, major depression, and other psychological conditions that actually hamper their ability to improve. So that's all the things we've learned. And now we have a huge behavioral health component to our treatment, and not just neurologic or from a rehabilitative approach like PT or ortho. We take it holistic. And so our goal is to continue to expand those opportunities, think outside of the box. When you look at the majority of patients who have had a TBI, mild TBI is what we see most of, they have negative MRIs. And so the MRIs, they do not show any type of any changes that are significant with a penetrating traumatic brain injury. And so you're left with, how do you diagnose it, right? And so it's one of the big things in Congress now and in the media is about what we call subconcussive events. And so that means that we have military personnel who are in high risk MOSs or occupations throughout the military, and they're exposed to blast injuries. And so the question is, we also see those patients oftentimes have symptoms that are consistent with post-concussive syndrome, but they never had, by definition, a TBI. And so we're learning so much from our patient population, and we're learning what works. And I think that's the biggest change that's happened over the last 14 years.
So what about biomarkers? Are we any closer to being able to have a blood test that says, boy, hey, this is a high risk, or this is consistent with a concussive injury?
That's one of the million-dollar questions now, and we've been doing a lot of research, and DoD, the private community, is really putting money into looking at what is the silver bullet for diagnosis, right? So biomarkers are out there. We are looking at how can we establish the biomarker for an acute TBI. But there's a lot more research needs to be done, of course. It's trying to find the right one in the setting.
So one of the things I've interviewed a couple ophthalmologists who kind of talk about, eye injuries and, their prevalence in the wartime. And one of the things that made a huge difference was ballistic eyewear protection. So in the same vein for TBI, I mean, you look at NFL, the helmets that they wear are a lot different than the helmets I wore when I was playing football as a kid. What is the military doing for prevention for these high-risk MOSs or places where you're at risk to have concussive injuries?
So there's several things the military is actively doing. One of the things you'll see is baselining. And so we're starting to do baselining more widely across the military health system and across the military overall. So our goal is to start baselining with all personnel before they start training. Interesting statistic is that the majority of TBIs that take place in the military take place in a training environment. So we have about 24 to 25,000 TBIs new a year. And since 2000, we've had almost 500,000 TBIs across the military system. Now, the challenge is that a lot of those acutes, they don't come in when they initially have the event. They have a concussion, as they say, they shake it off and they get back into the fight or they continue training. But many of them go on to have, or should I say a subset of them go on to have post-concussion symptoms that don't resolve within 7 days, a month, or even sometimes 6 months. And those are the ones that we end up seeing at NICOE and across the Defense Intrepid network, because we are a specialty care network. So we specialize in TBI and brain health. One of the things I would say, though, is that Congress has put forth the Warfighter Brain Health Initiative, and that really allows us to take a step back and look at TBI in a different way. So we want to focus on prevention. So that means education, building resilience, taking a lot of the tools and modalities that we use in treatment and putting them in the what we call left of bang, or before the injury actually takes place. And then we want to make sure that once the injury does take place, I selfishly say we do a phenomenal job of caring for our members, but once they leave us, once they leave the treatment facilities, how are we continuing to support them in their recovery? And so I think there's a lot of work being done in focusing on prevention from that way. We have a partnership with the NCAA, and you mentioned football and a lot of the athletics. And that partnership is unique because we're learning a lot from concussions in that space. But I make no bones about it, a concussion for a military personnel in the battlefield is very different than a concussion on the football field. I use the analogy oftentimes when you're on the football field and you have a concussion, the crowd stops, and everyone's holding their breath, waiting for that member to move and determine what's going to happen. They go out to the field, they pick them up, everybody cheers, and they take them off to the best treatment facilities in the world within 20 minutes. But if you're on the battlefield, that's not the case. There's no one clapping for you, there's no one there, and you oftentimes can't get to the highest level of care within 10 to 20 minutes. So it's a different subset of population. But our goal is to work before they get their injury, understand how to diagnose it, and help operational units do a better job of choosing the right equipment and supplies that can prevent it.
So my background is as a surgeon. So, operate for cancer, you take it out, you're cancer free. And so, that's the cure. Is there a cure for TBI, or do we treat the symptoms as best we can and it never goes away?
Here's the bright side. The majority of patients actually improve. Okay, so we have a tendency towards recovery from TBIs. So it's only a small subset. So when we look at it, now I've seen studies that go from 5% to 30% of patients have post-concussive symptoms. But we like to say about 15% of patients end up having post-concussive syndrome. That means they have sequelae such as headaches, dizziness, and even cognitive challenges. But again, 15% of that. And so for that population, it may never resolve. But a treatment, we do not have a treatment. We do not have a cure. We do have a very, very effective treatment through our interdisciplinary model, but still no per se cure.
So one of the things that has been a really sore spot about some of these post-deployment conditions is that they may be associated with suicide risk. Mm-hmm. Is there a suicide risk correlation with folks with TBI?
Research has not shown that TBI causes suicide. We do know that once you have a TBI, it does disrupt neuronal pathways, and so that makes you more susceptible to other conditions as well. And that's why when they stood up the program in DOD, it was TBI and associated conditions. Some of those associated conditions such as PTSD, major depression, and others that we know are increase your risk of suicidality. TBI in itself, though, may weaken the environment, but we have not seen a direct link as of yet. Research is still ongoing, and the verdict is still out.
So one of the things I saw in your bio that was interesting to me was that you were involved, or very involved, with pandemic response. Mm-hmm. So obviously we come out of a major pandemic. What did we learn, and what can we do better to prepare for the next one?
Oh man, that's a tough question, right? I mean, I have a very atypical career, right? I'm a physician by trade, but I was a U.S. health attaché. I ran a program in Africa for a pandemic, like you said, with USAID, and I've even, ran the Navy's global health division. But I think, what I learned from pandemic and I saw firsthand is being consistent. The program I ran in Africa, we worked with countries to understand their vulnerabilities in terms of full-scale societal impact from a pandemic. I was on the front lines of Navy for the pandemic, helping with the research labs around the world. So we did testing and other opportunities. I think the goal is to stay prepared. I would say the biggest challenge is we have periods of time that we're prepared because we make sure we have an inventory and we've done all the CONOPS, contingency operation planning. But then when a pandemic does not come for 10, 15, 20, 30 years, that planning gets lax. So I think one of the things we have to do as a nation is be consistent. Continue to fund the capability, because it's not if it happens, it's when.
Pandemics of the past have been natural pandemics, but one of the concerns is, sea burn, where this may be something that's engineered. What is military medicine doing to prepare for that possibility?
There's organizations within the Department of Defense, I would say. And I wouldn't say necessarily military medicine as much as I would say there's organization that's funding that supports biodefense. And we as medical personnel support those activities. We want to make sure that our personnel have systems in place for diagnostics, systems in place for how to address full-scale outbreak. But I think military medicine's primary focus is to understand the landscape, understand what the risks are, and be prepared for whatever comes down the road. That's what I always say, anywhere, anytime, is what we approach. Our approach to medicine.
So you're trained as a pediatrician.
Internal medicine, I was a med-peds guy, so
Okay.
Internal medicine and pediatrics, and then I did a fellowship in international affairs, global health up at Hopkins. Yeah.
So for those who don't understand military medicine, they're
Sure.
saying, what? The Navy has pediatricians? I get an internal medicine, maybe.
Sure.
Those are for old people, but how many pediatric patients do we see on active duty? Set the record straight. Why do we have pediatricians in military medicine?
Yeah, because we take care of beneficiaries. When you think about every member that's in uniform, there's potential of having children. Many of them are married, have families, and children are part of the package. And so around the world, we have military personnel stationed, Air Force bases, Army bases, Navy bases, Marines. And for each one of those service members that's there, they may have a family with them. And so children are part of that package. So we have to we stand ready to take care of families. They are part of what we call the beneficiaries of the military health system. And so children are a part of this family, and we do a great job of caring for them too. When I was in Iraq, during my first deployment many years ago, I was head of pediatrics for our EMF at the time. And hundreds of children came through that. Now those were local, but hundreds of children came through that facility. And here in Garrison, here in the brick and mortar back CONUS and our treatment facilities, we see many, many kids all the time, and different specialties as well. And so we're taking care of quite a few children in military health system.
Yeah, I mean, I found that in my deployments too, that wars don't spare kids,
do not.
and global disasters don't spare kids,
Not at all.
and military medicine's right there
It is.
for all of that.
That's
and,
right.
and so, I always have to, when people ask me, like, well, I don't understand why you have this and that. It's
Right.
like, it's a team effort, and it's definitely needed.
Yeah, 100% team effort. I have no doubt about it. And it's some of the reason why I love military medicine. I mean, I'm passionate about this uniform. I'm passionate about military medicine. And it has absolutely changed my life, and I wouldn't do anything over again. Because the experiences I've had and all the places I've gone and different types of jobs I've had, I don't think I would have gotten it anywhere else. And the Navy provided me a great opportunity to not just see the world, but to experience it from a whole different perspective.
So tell me a little bit about the initial journey to Navy medicine. How did you start on that pathway?
Yeah. So, I guess I look at Navy medicine in a way. I looked around at all the services and I said, which one gives me the most diversity? And I think any of them could have given me a lot of opportunities, no doubt about it. But I love that fact with the Navy, I could land, sea and air. There was all the opportunities. If I wanted to do dive, if I wanted to do flight, if I wanted to do surface, and even if I wanted to support the Marines, which I have, I thought the Navy was ideal. So I joined the Navy in med school, and so first year of med school. And I went through and I had a mindset of I want to be able to take care of everything. And that's why I ended up with med peds, right? And so I wanted to be able to take cradle, as we say, cradle to the grave, the full spectrum of life, in a sense. And I wanted to be able to do that in an intense fashion. So, with internal medicine, critical care is a major part of that training. Same thing with pediatrics. Pediatric critical care is a major part of that training. And honestly, when I first got in the military, I thought I would do a couple of years and get out and do something in the civilian community. But I got into the military early on, right after 9/11, deployed and fell in love with the experience. I mean, I absolutely never thought I would still be here some almost 25 years later. I mean, it blew my mind, but I enjoyed the experience. So then I fast forward, I decided to get into international affairs, into the global health space. And I did a fellowship up at Hopkins, and again, the experiences just took me to the next level. Navy afforded me the ability to be a U.S. health attaché in the South Pacific. I mean, that was a great experience. Almost 3.5 years there in Papua New Guinea. So I served Papua New Guinea, Fiji, Micronesia, Mauritius, many other embassies in that spot, in the South Pacific. I was a health advisor for U.S. government in that region. Experience of a lifetime. Prior to that, I was working with Uniformed Service University, but I was the principal agent for USAID and the U.S. AFRICOM program for a pandemic. And so that morphed into a disaster preparedness program. And again, experience I just couldn't have gotten anywhere else. So here I am all these years later, still loving every bit of it.
What was the most challenging aspect of that assignment in South Pacific? That sounds very interesting. What stands out that says, man, this was crazy, or this was really tough?
If you know much about population and development, Papua New Guinea is one of the most underdeveloped nations on the planet. Now it's skyrocketed. At the time I got there, I think it had the 10th fastest growing economy in the world at the time. There had been a discovery of natural gas of large magnitude, and it was a U.S.-based company who was doing a lot of the resource extraction there. It was excellent. So different companies there. I think the biggest challenge is isolation. And I had to travel around to all the islands because I supported the U.S. government in that region for health overall, not just for military, but for State Department and for Pacific and Indo-PACOM at the time. And so I did a lot of traveling. I think the isolation was probably the toughest part of it, but it was also the lack of resources. Strategically, different parts of the world are really strategically important for different reasons. And so we have huge partners in that region of the world, Australia, New Zealand, and those were partners in that space there. So I thought it was a great opportunity for me to understand and learn true development from ground zero from my partners from State Department and USAID. And so as a health attaché, I was the chief advisor to the ambassador there for health-related activities and all the ambassadors in that region. And so it was just new, but it was fascinating.
You talked about deploying to Iraq as the chief of pediatrics. Was there any really interesting PEDS cases or other clinical cases that you recall that said, wow, I'd never see this had I not been part of Navy medicine deploying?
Yeah. I mean, so we deployed as the first expeditionary medical force into a combat zone back in those days. We started out with the team. We didn't expect to see a lot of kids at first because it wasn't that type of mission. It wasn't a humanitarian mission. But quickly, once we got on the ground, myself as a pediatrician and my family medicine colleagues became invaluable when it came down to caring for children. I even had the opportunity to care for quite a few children in the intensive care unit, of our EMF. So quite a few interesting cases, actually. And I say some of them were a lot of head trauma, penetrating head trauma. I remember a case when we had a child who, as the old statement says, what goes up must come down. And we had a bullet wound that went up as a AK-47, full metal jacket intact. Went up, came back down, and did not mushroom at all. Just went right into the child's corpus callosum area. And at the time, all we had was X-ray, so you could see where it was. But that child did extremely well. Medevac that child out. We kept her there. ICU did what we do for penetrating head traumas without having advanced surgical capability. Got the child transported out to a out-of-country facility. She came back, walked in, and it was just gratifying to see that child. I learned a lot, though. I learned so much when it comes down to the rules, international rules, right? That was a different war. But yeah, so the amount of cases that I saw, pediatric cases, and the complexity of those pediatric cases in terms of just complex trauma, orthopedic trauma, and being the pediatrician to really care for them at that intensive level was just fascinating. You know, I did my training at Children's Hospital of Michigan, Wayne State up in Detroit, so I saw a lot of great trauma. I mean, it was a great environment. But I tell you, and it prepared me to go to Iraq. Now, nothing prepares you for the magnitude of trauma. Nothing prepares you for the sheer emotional aspect that it affects. But I knew that I was well trained as a doctor to take care of the patient that I saw.
So on War Docs, we often have some younger listeners and viewers,
Sure.
Maybe high school, college. What advice would you give to someone who's considering military medicine in any part of the military medicine team? What advice would you give them had they come to you?
Oh God, that's great, because I consider myself a huge strategist and a huge mentor when it comes down to life choices, right? So the first thing I would say to them, dig deep about what's your passion. I encourage them to look at where they are in their lifetime and say, you know, what do I want to do with my life, and do I have a passion for service and adventure? Because you can join the military, and it used to be a time you could join the military and just see patients just like you would in the civilian community, and potentially never deploy or never really truly go into the operational space. Those days are over, though. And so I think really and truly I would encourage them to say, if I have a desire to serve, if I have a sense of adventure, military medicine, and you want to do medicine, military medicine is where it's at, without a question at all. I wouldn't change a thing of my last 20 plus years in the military. And I think that most military docs, nurses, medical service corps, dental corps, who got out there and embraced every aspect of what military medicine is, wouldn't change a thing. I'm almost certain of that.
We've been speaking with Captain Carlos Williams on this special episode of War Docs Podcast in collaboration with OpMed TV. Carlos, thanks a lot for your time, and thank you for your service, and thank you for sharing your insights with us.
Thanks, Don. Appreciate it.
Thank you for tuning in to this special episode of War Docs, made possible by a partnership with the Defense Strategies Institute's OpMed TV. To stay connected with Team War Docs, visit our website at wardocspodcast.com. Follow us on social media for updates and subscribe to our War Docs YouTube channel for more engaging content. Your support helps us continue to document the experiences and contributions of military medicine professionals as we honor the legacy and preserve the history of military medicine for the next generation.